The National Health Insurance Scheme was established through the National Health Insurance Act number 2 of 2018 and operationalized by SI number 63 of 2019. The scheme is a mandatory initiative aimed at ensuring sound and reliable health care financing for all Zambian citizens and legal residents. It represents a cornerstone of Zambia's broader health policy framework to improve access to health care, eliminate financial barriers, and promote universal health coverage. As of November 30, 2024, the NHIS had registered about 3.5 million members, with contributions poured into a central fund to improve health system efficiency. Members benefit from a cashless system where insured services are accessed directly at the time of need. Furthermore, the NHIS has accredited 452 healthcare providers, which include public, private, and mission hospitals to ensure services accessible nationwide. I'll now move to the adequacy of the legal and policy framework promoting universal health coverage in Zambia. So I'll start with the key supporting frameworks and policies. The first is the National Health Insurance Act number 2 of 2018, and we also have SI number 63 of 2019. We have the National Health Strategic Plan running from 2022 to 2026. Then we have the 8NDP. We have Vision 2030, and lastly the Health Financing Strategy. Regarding the adequacy of the framework, we see that the legal and policy framework supporting UHC is comprehensive in its design and objectives, and the establishment of both NHIMA and the NHIS has laid the foundation for equitable healthcare financing and access. By pooling contributions into a single fund and promoting prepaid health services, the framework reduces financial inequities and barriers to care. So I'll just quickly run through the strengths and gaps and weaknesses of the legal framework. So in the first place, we see that one strength is inclusivity, where the Act mandates coverage for all citizens, including exemptions for vulnerable groups such as retirees and senior citizens classified as 65 years and older. Then there's a clear mandate for NHIMA. We also see a form of strategic alignment. In terms of gaps and weaknesses, we see that there's limited enforcement mechanisms, there's sustainability challenges, where we see the current contribution rate of 2% of basic income is insufficient to sustain the scheme, as evidenced by rising claims that exceed contributions. Then another gap is the accountability and monitoring. There's also a gap in terms of the equity in access, and lastly, the policy harmonization. I'll quickly look at some supporting figures and data. As of November 30, 2024, NHIMA had registered 3.5 million members, as I said. These are categorized into the formal sector, which makes up about 40.3%, the informal sector, which is about 46.7%, and the exempted category, such as retirees, senior citizens, which make up 13%. Then we also see that the Global Fund Health Insurance Subsidy Program supports 16,000 households under the Social Cash Transfer Program, which represents only 1.3% of Zambia's 1.2 million poor and vulnerable. We also see that NHIMA solvency is under threat, with claims payments rising from 677 million kwacha in 2019 to 1.7 billion kwacha in 2024, and this has outpaced contributions. Now look at the mandate and operations of NHIMA in advancing universal health care in less privileged areas in Zambia. So we can see that NHIMA is mandated to implement and manage Zambia's National Health Insurance Scheme as a means to advance universal health coverage, and some of NHIMA's key responsibilities include managing the National Health Insurance Scheme, or NHIS, ensuring access to affordable health services, accreditation of health facilities, targeting the poor and vulnerable, as well as M&E on health service delivery. And then On the operations of NHIMA in less privileged areas, we see that NHIMA has employed various strategies to extend healthcare services to less privileged and underserved populations as follows. In the first place, it's enrolled and is enrolling poor and vulnerable populations in collaboration with the Ministry of Community Development and Social Services. It's also extended coverage to the informal sector, as well as accredited healthcare providers, which it began doing in December 2019. As of November 30 last year, 452 facilities have been accredited, broken down into 152 public facilities, 238 private facilities, 1 NGO facility, and 61 mission/mini hospitals. Then another strategy is the use of technology, where digital platforms have been deployed for registration and claims processing. We also see that there's been the use of mobile and outreach clinics. Then there's data and figures that have been included to support some of these claims. I think I'll now move to the analysis of NHIMA's mandate and operations, where we see that some of the strengths include structured risk pooling, where NHIMA effectively pools contributions to reduce out-of-pocket payments for vulnerable populations. It also employs the targeted outreach, where collaborations with local leaders and NGOs are used to promote inclusivity. Then there's also an accreditation drive, like I alluded to, which deals with increased accreditation in rural areas to ensure broader service access. In terms of the weaknesses, we see that there's infrastructure deficits, where many accredited rural facilities lack the equipment and personnel needed to deliver quality healthcare. There's also low informal sector contributions. There's ICT challenges, as well as the dependence on private facilities. In terms of the adequacy of the strategies used to register poor and vulnerable people, including the informal sector, we see that NHIMA has employed several strategies to ensure the inclusion of poor and vulnerable populations, as well as the informal sector workers. And these strategies have been made to overcome financial and geographical barriers, while at the same time fostering equitable access to healthcare. Some of these strategies, I think I'll just read one or two, include collaboration with the Ministry of Community Development and Social Services, as well as targeted outreach campaigns. We now move on to the adequacy of the strategies used to register poor and vulnerable people, including those in the informal sector. So we see that the registration of poor and vulnerable individuals is broken down into 3 categories that include the poor and vulnerable, with a percentage of 100%, and then the currently covered, where there's a percentage of 1.3% currently covered, and the uncovered population of about 98.7%. Then in terms of contribution patterns, we see that the informal sector contributes about 40 to 50 kwacha per month on average, whereas the formal sector contributes about 2% of basic income. Then the utilization rate for the informal sector is high, whereas for the formal sector it's moderate. PMRC's analysis of this adequacy, some of the strengths include the collaboration with the MCDSS, which streamlines the identification of poor and vulnerable groups through existing social welfare systems, as well as engagement with traditional leaders, which enhances trust and community acceptance of the scheme, as well as targeted subsidies. Donor-funded pilot projects such as the Global Fund Initiative demonstrate the potential for scaling up coverage. In terms of weaknesses, you see that there's limited coverage, where only 1.3% of the poor and vulnerable population are covered. There's also low informal sector contributions. There's geographical and technological barriers, as well as the sustainability of subsidies cannot be adequate. I'll now hand over to Mrs.
I'll look at the challenges and some of the recommendations by PMRC. So what are some of the challenges that NHIMA is facing? The first one is lack of treasury appropriation for the scheme's operation. The NHIMA Act, when it pertains to the fund, states that treasury appropriation through Parliament is one of the sources of funding, especially for the scheme. NHIMA has not received appropriation since inception. And we've just seen in the current 2025 budget, that's when we've seen a minimal appropriation from the Treasury. So there was lack of capital injection at the onset of the scheme, where we saw that 10% of administrative costs also came from the same contributions from the population. There are high claims from exempted categories. So senior citizens and retirees who are exempted from contributions, and they represent 13% of those that are registered under the scheme, have got a higher utilization. NHIMA, data shows that as at November 2024, NHIMA had paid up to 847 million to claims for these groups, with an annual average of 170 million. There's limited contribution base. Contributions are pegged at 2% of basic pay, slightly lower than the 5% gross income recommended by the studies that have been done by NHIMA. Comparatively, contributions rate in other African countries are higher. If we compare to Tanzania, Kenya, and Rwanda, they are at 7%. Generous benefit package. The 16 benefits package was designed based on 10% contribution model, but remains unchanged despite the reduction of 2%. This mismatch strains the financial resource. The time when they were coming up with the time when the package was being come up with white people would access, it was based if an individual would make a 10% contribution, but the contribution still remains at 2%. High utilization in the informal sector. The informal sector contributions first are irregular, and the average is about 40 to 50 kwacha per household per month, and the only person who contributes in that family is the head. And many only contribute when they are seeking health services leading to moral hazard. Quality gaps in public health care. Public facilities face challenges of shortages of drugs, equipment, leading to high referrals to the private facilities. These referrals have resulted in the NHIMA to incur high cost reimbursement. I think all of us are of the fact that the services in our public health facilities, including the first level as well as the public health services, have been bad, such that if somebody goes to seek medical attention, most of them are given prescriptions, or if they need high level medical attentions, they are sent to the private sector. So the interaction between NHIMA and the private sector then has led to some of the problems that the scheme is facing. ICT and fraud management issues. NHIMA lacks a robust IT system to monitor claims and detect fraud activities. Public health providers in particular also faced capacity challenges in utilizing the existing system that results in efficiencies. We've seen that NHIMA contributions and registration are way simpler, but for them to detect, they do not have a continuous monitoring system that will enable them to detect claims day in, day out. Poor public perception. Misconception about the schemes, especially among the informal sector, has led to low compliance. Many view NHS as a free government service rather than a contributory program. Just to look at some of the data that we have, especially on the exempt members and their financial impact. As at November 2024, senior citizens and those retirees, 449 were registered, and the annual cost of NHIMA to clear their claims and be able to provide for them services was 170 million. And then if we look at contributions and claims utilization, the informal sector contributes 2% of their base income, that's the formal sector, and the utilization is moderate, the claims ratio is balanced. The informal sector that pay 40 kwacha to 50 kwacha, their utilization is high and their claim is imbalanced. The exempt population, who are not supposed to make any contributions, their contributions are none, utilization is very high, and claims ratio is very high. For the informal sector, one of the reasons why their utilization is high is because it's just one member of the family that is paying the 40 to 50 kwacha, but then they have all these beneficiaries in that scheme that pay nothing, and that's a different to the private insurance schemes. In a private insurance scheme, you pay as a family, and you find if you look at some of those schemes like Prudential, where as a head of the family, if you're paying 20,000, everybody else who is on your scheme will have to pay something. Whereby you find annually a family will be able to pay about 100,000, but that's not a case with NHIMA. So analysis of some of the systematic gaps by PMRC, funding gaps. NHIMA's reliance on contributions without supplementary treasury support has left the scheme underfunded, particularly for the exempt population and the vulnerable groups. Operations or mismatch. There's a disparity between contributions and the benefit package where it creates sustainable financial pressure. As indicated in the beginning, the package that is under NHIMA is supposed to be funded by 10% contributions, but the contributions are only 2%. Quality concerns. Public facility deficiencies push patients towards costly private sector facilities that is compounding the financial strain on NHIMA. What are some of the recommendations that we give on behalf of NHIMA? There's need for treasury appropriation that's adequate, because if we look at our current appropriation to NHIMA is 1.5 million. But if you look at the statistics that came out recently, is that every month NHIMA needs to pay out 160 million kwacha towards claims for various providers, and they only have 100 million a month. So they have a shortage of 60 million a month, translating to over $1 billion in a year. But as a country, we've only given them 1.5 million this year. Contributor revision, there's need to increase the base of contribution for all segments of contributions. There's also need to reform the package. Then there's also need for awareness campaigns for the public in order for us to improve the understanding of the NHIMA packages, as well as the obligation to increase compliance and trust. What are some of the challenges that are being faced by the health providers, the people that provide services under the scheme? Inadequate infrastructure, especially health facilities in rural areas. They lack adequate equipment, medical supplies, and infrastructure to deliver the required services. Delayed disbursement. Healthcare providers often experience delays in receiving disbursements from NHIMA, thereby creating delays in cash flow. Overburdened facilities. With the introduction of NHIMA, there's been a surge in patient visits to accredited facilities. Hence, most facilities are not adequately equipped to handle some of these cases. Inconsistency service standards. Some accredited facilities lack the capacity to meet NHIMA quality assurance standards due to resource constraints. Geographical barriers. Accredited facilities, especially in remote areas, often face logistical challenges such as road infrastructure and transportation limits, which hinder the timely delivery of medical supplies and access to specialized equipment. The challenges faced by NHIMA and accredited health facilities highlight systematic issues that require urgent attention. NHIMA reliance on the formal sector for contributions, limited outreach to informal and vulnerable populations, and operational inefficiencies pose significant risks to sustainability and the effectiveness of the scheme. On the provider side, infrastructure deficiencies, personnel shortages, and reimbursement delays exacerbate the challenges of delivering quality health care, particularly in underserved areas. What are some of the recommendations and the welfare that has been put in place by PMRC? There's need to strengthen the financial sustainability of NHIMA. How do we do that? There's need to change the contributory base. There's need to transform from the 2% basic income to the 2% gross. As recommended by the actuarial studies, this will ensure solvency until 2030. Gradual increase of contributory rates in line with actual forecast to maintain financial stability. This especially has to come, is key, especially when we factor in inflation. Diversify funding sources. Introduce taxes such as the sin tax on alcohol and tobacco to subsidize the scheme. Because there are issues of tobacco that has a negative effect on health, both for people who smoke and for non-smokers. So then there's a need to tax this there's need to introduce such a tax to ensure that this also just goes towards the universal coverage of health. Implement a small surcharge on airtime and VAT, especially earmarked for NHS. We have Rwanda where they are getting money from telecommunications as well as money from fuel to fund specifically for healthcare coverage. Explore partnerships with international organizations to secure additional funding, like the way they are doing with those that are funding the vulnerable. Treasury appropriation. Allocate funds to cover exempt categories, including retirees, senior citizens, and vulnerable population, ensuring their exclusion without overburdening the scheme. As government that has enabled that the 65 and above, including pensioners, should get free healthcare services, there's need then for government to foot that bill for the exempt population. There's also need maybe to reform the package, adjust the package to the current contribution level. If we maintain the current contribution at 2%, then there will be need to reform the package of what should be accessed through the scheme. Introduce a tier benefit package depending on the differentiated contributions that are being made by members. Enhance public awareness and compliance. Nationwide sensitization is needed. Continuous engagement of local leaders. Also behavioral incentives to enable people to continuously contribute. We saw NHIMA at some point scrapped off the 4 months waiver, where you can, if you pay now, if you register now and pay, you'll be able to access the contributions there and there. So those are some of the things that annually NHIMA should also try to do. Improve service delivery in public health facilities. There is need for the country to improve self-deliveries, to improve service delivery in public health facilities. If this is done, then there will be a reduced interaction between NHIMA and the private sector. Also, there's need to expand accreditation, especially for rural centers, to reduce reliance on the private sector. Enhance monitoring system. There's need for NHIMA to have a robust monitoring system to ensure, in order for them to detect fraud and overuse of the scheme also by patients. You find a situation by the time NHIMA is flagging off a healthcare provider, a lot of damage would have been done. So also there's need to strengthen ICT and fraud detection. Also there's need for the country to use data-driven decisions to make use of real-time analytics to identify trends, allocate resources, and evaluate impact. On this one, NHIMA has been doing actuarial studies year in, year out to determine on how much money they need annually for them to be able to be sustainable. But looking at our budget allocation even for 2025, this shows that the decisions within that decision was not based on data. Expand coverage for the poor and vulnerable populations. Interrogate community-based health programs within NHIMA. In conclusion, PMRC indicates that NHIMA plays a critical role in Zambia's healthcare system, driving efforts to achieve universal health coverage and reduce health disparities among populations. While significant strides have been made in establishing a framework and operation strategies, challenges such as adequate funding, limited registration in the informal sector, infrastructure gaps, and inefficiency in service delivery is hindering this scheme to its full potential. Addressing these challenges require a multifaceted approach, including enhancing financial and human resource, strengthening monitoring and evaluation system, improving outreach and registration mechanism, and fostering collaborations with the stakeholders. By implementing the above recommendations, NHIMA can overcome its current limitations and make healthcare more accessible, affordable, and equitable for Zambians, particularly the poor and the vulnerable. Chair, I submit.
I think I just wanted to find out your comments on the population. Those who are 65 years and above, they don't contribute anything. But when you look at the claims, I think it's a huge sum of money. Now this scheme is the government, it's the baby of the government. Is it possible that we recommend in our submission to the executive that this 13% or any percent should be paid by the government because they don't pay NHI, but it's a very good number, and the government should be responsible. That would be ideal for us to comment in that manner. Thank you.
For the NHIMA program, since its formation, I think the first 2 years there was no expense. The first 2 or so years there was no expense at all. They collected good money, which has not been utilized fully. But in your some of your recommendations, you are saying they should have been given some capital injection, but they were starting with the almost 400,000 kwacha, which was collected in the first year, second year. So to me that sounded like a capital injection. And then two, you are talking about enhancing public awareness as one of the strategies to improve the packaging. But then when you see the jump in the claims, the jump in the claims is over 100 times in the last 3 years. So that shows a very high public awareness to the claims, because if the claims were jumping from 400,000 to 700 to 1.7 million, so there's huge jump. But also overall is that where has NHIMA taken, because when you add the figures, the subscriptions, the money collected versus the claims, there is a 400,000 something which is unspent. So where has that gone? Have you taken care to analyze in where it has disappeared to as researchers, so that we can find an amicable solution to this issue? Thank you.
Thank you. I think I'll answer the first question, then I will take the second one. So regarding the first question, in terms of what we should do to our colleagues who are retired, these that are not contributing anything, but data shows that there is high utilization and high claim from a number of health providers. So I think studies have shown that in many countries where the National Health Insurance Scheme is running, there has always been a subsidy that comes from government to be able to push on certain things such as that, so that we can be able to cover for that deficit. Even when you look at countries like Kenya that have had such act and the policy in place for almost like 58 years, and they recently replaced that act, you realize that they have been evolving, and at some point they had to look for where they can do some tax surcharge so that they can get some money to be able to fund the National Health Insurance Scheme to avert the deficits that may come as a result of helping the age group that is exempted from basically paying contributions. Thank you.
Thank you very much, Edie. Thank you very much. Maybe to just also complement what Edie has said concerning the exempt population, we have countries like Egypt where government has to contribute 13% of the minimum wage of that country for anybody who's exempt, who's not able to pay. So in our country, what does that mean? That means our country's population is 19 million. And we have a working age population that is about 11.5 million. We have the labor force that is 4 million, and we only have the employed that are 3 million. So, pardon? So that's coming from my head. Sorry.
Let's go for 1 million.
Okay, so 21 million of our population, entire population, 11.5 million are a working age population, that's 15 and above. And then we have the labor force is 4.52 million, with only 3.9 employed, and 540 are not employed. This is the working age population. We're exempting the retirees. So we have a segment of population that are retirees, plus if we add the 540 that are unemployed, but they are also accessing this, they need to access this service. Then there's need for government to be able to fund, to be able to pay for everybody who's not employed. There's need for that because the Egyptian government is paying 13% of the minimum wage. So if we say our minimum wage is 1,300, so 13% of that multiplied by the population that should be paid for, that includes those that are retired. Because government's mandate is to provide primary health care, but since the introduction of NHIMA, we feel one or the other, government has put its hands off a bit to be able to do that. How do we explain the money that is paid for primary health care, for hospitals, for equipment, medication, but year in, year out, we have shortages that are being put in place. So it's like there's a relaxation because government feels that NHIMA, people will go through NHIMA and they'll be able to access these services. Secondly, there was an issue on public awareness in conjunctions to claims, where we've said the claims jumped from one year to the other. Remember, like a few people, a few heads of households are registered and they're paying. But if we look at the trail of dependency that is there is a lot. You find a head of the house who is in the informal sector is paying a 50 kwacha, but their dependents are not paying. So, but they're accessing medical health. So then when it goes to claims, there's a big jump. You find somebody paying 50 kwacha for a household of 7 people. So then when it gets to claims we realize are higher than what has been eventually being registered. So then there's need. So then there's need for public awareness, but then also for us to ensure that each household each and every member of the household is making a payment like the way it's done in the private sector. Yes, there's still need for public awareness to be done because we only, of a population of 21 million, we only have 3 million people that are registered under NHIMA. That number is also very minimal. The reason why people are not registering, it comes in to say people still feel like government should continue to give them free healthcare services. There was also a question that has to do with capital injection, where we said in the first 2 years, NHIMA had 400,000 without them expending it. So that's one of the conversations that we had as we are coming to say NHIMA as a public institution needed for them to have their financial reports online, but they're not there. Because we were also interested to look at the administrative costs from the beginning up to now to see how have they been spending money. Because remember, this NHIMA fund also accounts for salaries, it accounts for allowances, it's also accounting for the administrative costs which they are paying at 10%. So it would have been good if those financial reports were online, that we're able to put them also to enable us to analyze how has been the expenditure, administrative expenditure from inception until today. Because today we might be claiming to say no, we need to increase the contributions. We are proposing to tax the already overtaxed people. We are saying government should put money. What if the problem is with the administrative costs? So we also needed to do that. That was one of the challenges that we faced. There was an issue of saying between the contributions and the claims, there's a 400,000 accounted. The figures that we got as of December 2024 indicates that NHIMA claims at 160 million compared to the contributions that are 100 million per month. Yes. per month. So like their monthly contributions that they're able to collect is 100 million, but their claims are 160 million. So yeah, so one or the other, there's a deficit that should be covered. So yeah, we did not realize that there's a 400,000 that was being unaccounted for. Thank you.
Thank you so much, Chairperson. Thank you very much, our witness, for your submission. I'm still, failing to understand where all this, issue of, asking the government to come in, government do that, government do this. If you look at the person who is mandated to contribute to NHIMA, we are looking at, those who are employed, and how many do we have as researchers in the country, and this is mandatory. Then we're looking at those that are self-employed. How many are they as researchers? We need answers. We are looking at those, established, residents. So now, if you look at the category of people that are mandated to contribute to NHIMA, I think the issue of, government may not come in so prominent like any other presenter who say, government do this, government do this. Like us from Kanyama, we say, Boma Yangadeo, all the time. So for me, that actually, does not sit well with me. So now, if we look at that class and look at the population, you realize that I don't think we are talking about 4.6 million people that are, what is the population? So now, you as researchers, have you ventured into looking at the implementation and the enforceability of this program? Because I don't think there are mechanisms that have been put in place at implementation to ensure that all those that are self-employed contribute, all those that are employed contribute, all those established residents contribute. So not until we look at it from that angle, that is my way of understanding. Not until we look at it from that angle, are we going to be able to probably, ask the government, probably we even come with a tangible figure or percent that we would want the government to. So have you interrogated or audited the implementation of this program, looking at people who are supposed to contribute, the employees, self-employed, established residents, and the like? I submit.
When you look at the rate at which the claims have been growing at NHIMA, 2020 they only had 29.5 million claims against an income of 677. 2021, 814 income, 177 claims. But 2022 the figure jumped to 844 million kwacha in 2022. In 2023 it was even worse, 1.7 million or 1.7 billion. 1,700 million kwacha. 2024, 1.7 billion takes to 1,762 million. It's a clear indication that the bucket in NHIMA is leaking, and the leakage is getting wider and wider. But what I've seen from main submission is pushing on the income side. Let's increase. Let the government do this. Let's pour more water in a leaking bucket. Are we going to solve the problem by pouring more water in a bucket which is leaking, other than closing the leakage before again we pour more water? Thank you.
The issue of capturing more members from the informal sector, I think this is where it is imperative. I think we have seen that in terms of NHIMA getting very far away from town or to go to underserved areas, they have not done so much. So this is where we need them to do more sensitizations, particularly in the informal sector. They still need to do more sensitization in market areas. They still need to do more sensitization in the areas, particularly in the farming communities. And once that is done, probably people will be enlightened and understand why they need to be able to subscribe to this fund. But then also coming to why should government come in to help the already sinking ship like NHIMA? Of course, I think, like you have rightly put it, that no, many of the witnesses that have appeared here talking about are basically giving you similar. Apart from that, I think one thing that I tend to see here is that NHIMA, the first 2 years when they had not started the implementation of the program, that could have been an investment phase for them. And we should be talking about, I think many insurance companies, you realize that they invest in various money instruments. And we need to interrogate NHIMA to be able to understand what is it that you are doing with your money apart from paying, receiving and paying out. Because we need to grow this fund, and it cannot just grow by sitting this money in the bank. So we probably need to grow this money into various money instruments. And so it is one of a side recommendation that would actually offer to NHIMA that they really need to go out there and look at mechanisms of how they can work with the other capital markets to grow their financial portfolio. Other than that, of course, I think we can rightly put it that NHIMA can work side by side with government to find strategies that are very critical in terms of how they can be able to survive. We have seen also, I think, this jump in terms of claims. When you look at the way NHIMA has been accrediting a number of service providers, I think the jump is between the time NHIMA brought on board the private sector. And so NHIMA needs to be very careful in the way they trade or the way they interact with the private sector, particularly when it comes to creating ceilings under which us as members are supposed to claim. Because before they actually, this time around when you go, you can actually, the facility will tell you, under NHIMA, you can only access this. If you have another insurance, you'll see that the services will be slightly different. So it is only now that they have put certain ceilings, and I think that is the right way to go. But it is slightly late, but let's see how far they can go in terms of trying to create a model which probably looks at how they can safeguard their contributions, because it looks like the private sector really hammered them so much that even the jump, sometimes when you look at it realistically, it is so much for us to explain why should you jump up to this much. There are a lot of frauds that can be detected from that arrangement. So, yeah.
Yes, Chair. Maybe just to put into context what ED has said about private players, I just did a cross-check analysis. What happened between 2021 and 2022? As at 2021, let me start from 2020. As at 2020, we only had 9 private players in the scheme. When it came to 2022, we had 157. In 1 year, they registered 157. And we saw a jump of claims. And we saw a jump in claims from 1.1 billion to 1.7 billion. So that's what we are looking at. So it goes back to say, for NHIMA to be sustainable, we need as a government to work towards to reduce the interface between the private sector and NHIMA. Even if we say today, we say no, let's increase contributions. Remember the medication we import. So then the microeconomic fundamentals of this country will still not be able to sustain the increase, because even for private premiums, you realize that if you are subscribing to a private provider of a scheme, every year there's an issue that comes in of inflation. Premiums go up every day. So does it mean, even for us, annually, we should continue having NHIMA increasing the premium for us to be able to sustain the interface between NHIMA and the private sector. In conclusion, Chair, maybe I don't know whether I should conclude, but I just wanted to submit what I came across on how the national health insurance is being done in Egypt. It's a very interesting case on how they have expanded the contributory base. I think I was talking about it in bits and pieces as I was speaking, but I just wanted to bring it to the fore. So for NHIMA, they have employers that both private and public that are paying 1% of their income. Then they have got the employers. So they have the public employers that are paying 3%. And then they have got private employers that are paying 3.5%. But in our country, it's 2%, 1% employer, 1% employee. So for them, they have left the employee to have 1%, but their employers, they are ranging from 3 to 3.5. And the self-employed are 4% of their monthly income. And then government has stated they are paying 5% of the national minimum wage on everybody.
Just there. So the self-employed are paying how much?
Are paying 4% of their monthly earnings. So these are the informal sector who are paying 40 kwacha in Zambia.
So basically you must understand that it's country context. So some countries have clear mechanisms where you can identify who is in the informal sector. You can identify clear who is self-employed, who is doing what business. Clear. And so you are able to reach them.
So no chair with that one.
It's very difficult to do that, and that's why we are trying to look at your idea.
Yeah, the issues of informality in our country is
Yes.
hindering both ZRA and any other contributory that we need to make.
Yeah.
But for those that we're able to capture, we need to maximize.
Yes.
So then the 40 kwacha that the head of household is paying, and they have a trio of dependents, that trio of dependents also should be able to pay, because in Egypt, even the formal employed, while I pay 1% of my salary, that even me as a former employed, I pay 1% of my salary, but that also still covers a trio of my dependents. They pay nothing. That's also what is the same in the informal sector. So we need to ensure that even the formal employed, as much as they are paying the 1%, they are also their dependents should pay. That also goes to the informal sector. If they are paying 40 kwacha, then all their dependents pay nothing. There's something that also the dependents should pay to ensure that there's sustainability. So we can start with the people that we've captured. Because we are desperate as a country, and NHIMA should not fail. So those are some of the things that we should do. And then the pensioners pay in Egypt. I don't know whether their pensions, the monthly pensions contributions are so nice, because I know in Zambia it's not the case. Pensioners are getting less than $100, like less than $100, 180 and something. So then that also becomes a disadvantage. And then government has said also pays 5%. So these are some of the things that with what we use, we can maximize with what we have to ensure that as we are rolling out this scheme, we continually look for strategies on how can we maximize with what we have, both as private players as well as government and research institutions. I submit, Chair. Thank you.